ചേച്ചി അയച്ചു തരാൻ പറ അന്വേഷണം.
അടിക്കാനോ?
Hi, Vanita madam. Surya Sumar, Malayali.
Maybe Bengali. We didn't read the message also. Maybe Bengali.
Good evening, Mr. Saji. Are you around?
Good evening, ma'am.
Yeah. What about the recording? You would be doing it, right?
Yeah, I'm doing it.
Yeah. Did we retrieve the recording the previous session?
No, ma'am, there is some issue. I said no last time that somebody had taken. I've already given to the team to just recover it. Let's see how to go ahead with that. So that's the reason I thought this time what I'll do means I'll ensure that I do the recording from my end. Last time somebody has taken over, maybe because the host might have given okay to that person. That was overwritten, and that person kept the phone on with his cover closed.
Okay.
So
So
that's the reason you just see that black
you can
hole.
retrieve from that person also.
Yeah. So this time I don't want to take a chance. So I just thought I'll just have it. I'll be there for till that entire thing is over. Who all should I make the host, co-host?
Dr. Mohammed Salman,
Mohammed Salman.
and
Okay.
I'm not okay. I'm not seeing the
I am him.
presenters of today. Can you see Dr. Tejal and Dr. Anil Vasudevan?
Yeah, Tejas. Dr. Tejas. One sec.
Dr. Tejal Shah.
Anil Vasudev. No, not yet.
I don't think can it
Both
go
of them
feedback?
have not joined.
Okay,
So I've informed the
because
leads here. Informed President elect. Everyone, I informed them that 6:30 we have the call.
okay, I messaged them. Would they be joining?
Yeah, President sir told me just inform him 5 minutes before the call, so he'll join. Yogesh sir is in another meeting, but he'll join at 6:30.
Hi, Vanita. Hi, Vanita, you're muted.
Madam, you are muted, ma'am.
Good evening, Dr. Vasant.
Hi.
Good evening, Dr. Vasant. How are you?
I was in Dubai actually
Very fast.
at pediatric unit and
അതല്ല അയാളാ 25-ാം
hey,
Dr. Vasant, you have to unmute yourself.
yes, and yeah,
Okay. Thank you for coming in, Dr. Vasant.
yeah. Thank you. Yesterday, day before yesterday, there was one update in Dubai. That IAP branch Dubai is there, no?
Okay.
They had done one update. 2 days update was there. So it was very nice. The crowd of 300 pediatricians were there. It was very good. They had nicely arranged. It's a 2 days total. And about all pathology, nephrology, infection disease, and mainly neurology they have covered. We
Interesting.
four faculties from India, we were there, and
Okay.
again I installed also that they this year they were wanted to install also last time. They installed the present there, and very good all from and Abu Dhabi and Dubai. There about 250 pediatricians were there.
Good evening,
Interesting.
President Saab.
Good evening.
Good
Back
evening,
to
Dr.
India, boss.
Yogesh.
Back to
Eh?
India. आ गया इंडिया में.
आप
Good
इंडिया
evening,
में
Dr. Yogesh. Welcome back to Bahrain.
या
Good
नो
evening.
मैडम गुड इवनिंग.
योगेश भाई को अडॉप्ट कर लो तुम लोग बहरीन में.
Can anyone send a reminder to Dr. Anil? I don't see him responding in WhatsApp.
So I'm here. I'm here. I mean, I'm sorry. I don't use WhatsApp.
I'm sorry, Doctor. Hi, Doctor. Nice to
So,
meet you, Dr.
nice
Vanessa.
meeting you.
Yeah, I will introduce
So,
you to the group. I'll
Hi.
introduce
yeah,
myself to you before.
I'm sorry. I mean, I've not responded because I don't use WhatsApp. So that's why
I was
probably
told.
some.
You
I
are
was
a
told
lucky
you
person,
are a
Anil.
rare specimen in this time of
Anil, you are lucky person. Really, you are not using WhatsApp. Really, no.
Good evening, Vasan sir. No, that's
How can we survive as a president without
Hi,
WhatsApp?
Dr. Anil. Can you tell us how you can don't use WhatsApp? We try this.
no. I mean, if I need to communicate,
maybe
probably by
we'll have
mail.
this in the part of discussion. We'll need a tip or two about it. But he does have a WhatsApp. Okay. I think we still have 3 minutes. In the meanwhile, we can continue our tete-a-tete prior to the actual session.
Mohammed Salman
Wonderful
sir,
to see.
namaste. Salman sir, namaste.
Dr. Mohammed Salman, that's the way we greet in India.
Yeah, hi. Good afternoon. Hi.
You know. Really,
Good evening, Vanita.
Hi.
Good evening,
Hello,
Doctor.
Mama.
Glad you could make it.
Yeah.
Sorry, there was some confusion and you were logged in yesterday.
Well, better that's a good thing about a Neelam. She can make it. She always make it. Hey, you
Thank
boarded,
you.
Neelam? Neelam,
Yeah, it got delayed by 20 minutes. So I thought might as well
Yeah, you
attend.
can catch a glimpse of us prior to
Oh,
your
you are
flight.
I can see a lot of people. Very nice.
Actually, we expecting 500.
yeah, she's
Yeah,
in the waiting area,
500.
I think.
Apart from India, we had 500 registrants. So people are ticking in some more to register.
Oh, we will go for some physical activities. Physical, Vanita.
We did have one in November.
November.
Dr. Yogesh was around, yes. We can have one next year sometime. You can plan that. Should be interesting too.
You mean this year?
25 is it planned? Anything?
Apart from, we have planned ahead for 6 months as monthly events, but not any physical event. We can still plan that for the next 6 months.
Maybe there will be one event, pediatric conference. It will be in either end of October or November.
Okay.
It's not only AMH, but it is Bahrain conference. So maybe you take part of this to make invite the audience and speakers to attend the event.
Yeah, you
Plus,
can
we
involve
maybe
some
organize
few
workshops.
faculties from IAP.
Yeah, we can coordinate with IAP for some of the speakers and exchange of know-how. Yes.
Yeah, that will be the better. So
yes,
that October or November conference, few people can join. No issue. Yeah. So Dr. Yogesh will be in touch with you.
We already met the head of pediatric department in AGU. He's the chairman of the conference.
Very good.
Last visit.
Who is there?
Dr. Just I want to remember the name.
In IAP?
No, in
IAP,
AGU.
Dr. Ranjan.
Yeah, Ranjan
in
is
AGU.
Ranjan is there. Ranjan is India. Who is managing this?
He meant people from Bahrain he was trying to introduce.
Yeah.
From IAP, Dr. Ranjan, Dr. Basavaraj, and Dr. Yogesh have visited us.
Yeah, I
in the
know.
previous.
Yeah. So it's already 6:30. Can we start? Should we start?
Yes, it is time. Good evening. Welcome everyone for the February session of IAP-AMH Pediatric CME. For those of you who are attending for the first time, we are having monthly CME sessions in coordination with IAP in pediatric subspecialties. This would be on the 4th Sunday at 4 p.m. Bahrain time, 6:30 Indian Standard Time. This session, the pediatric subspecialty is pediatric nephrology, and we have experts from IAP delivering concept talks in pediatric nephrology. Before going to introduce the speakers and getting started with the topics, let me introduce myself. I'm Dr. Vanita. I'm the host and the moderator for the session. And I would like to open the floor for Dr. Vasant and Dr. Nilima for a few words of encouragement before we proceed with the actual CME. Dr. Vasant, please, a few words from your side, and Dr. Nilim for...
Good evening, all. I'm Dr. Vasant Khalatkar, President of 2025 Indian Academy of Pediatric. Bring greeting from Indian Academy of Pediatric to you all. It's really as a thrilling experience to have a webinar like that's a joint webinar. That's a IAP Bahrain branch webinar with the American Mission Hospital. It's really a great job. What we were thinking, the beyond to go beyond border, and we have reached to beyond the border, and that this credit goes nothing to none than Dr. Ranjan, our soldier from India, who is always instrumental in such things, and Dr. Vanitha, really, it's a great. All because of your all efforts and this thing is possible. We hats off to you, and Dr. Muhammad Salman, President IAP-AMH. I think you're the most instrumental person who is always behind these webinar. And definitely our Dr. Neelam, who will be the president for next year, she is going to follow the same tradition. After that, like after Basavaraj, I am following the same thing. Our Dr. Yogesh, secretary, Dr. Basavaraj, our president, and Dr. Atanu, our treasurer. They are very much, we all are keen, and not only we are all are, they all 47,000 members are really thrilled to have this type of webinar, and this we are getting the faculty, Dr. Anil Vasudevan, Dr. Tejas Shah. Really, it's a this is the thing we want. That exchange of knowledge is very important. Why I know when there is an exchange of knowledge from country to country, it will really make a difference. For example, day before yesterday, I was in Dubai, and it was a pediatric update with installation ceremony. I installed their president in Dubai. That 2 days update, it was so meaningful, so good. We had a few questions about health status of Dubai. Then these people had there were 4 speakers from India and rest of the speaker from some UAE, US, and like that. But it's so good exchange. We had a very good questions. They had a very good questions about a vaccination. I presented on a neurology and infectious diseases, that emerging, re-emerging infections. See, the scenario is different, but when I was talking about the emerging infection, like we had a Guillain-Barré syndrome here, we had a this diphtheria here, chikungunya here. They were saying that we don't have this much, but overall scenario, whenever it comes, they say they accepted that we should be very much updated for that, and it shows any infection or any thing disease, it's never have a bounding. It can be in Bahrain also, it can Oman also, it can be in Nepal also, it is the same. So this exchange is very important. That's why when I conducted this Hyderabad PEDI conference as a president, where I got installed, I called near about 45 faculties from overseas, from out of India, and they presented so nicely, and they were presenting so. And one of the thing I'm telling with a proud that we are having some good modules that we said it's a workshop like a module, and one of the two modules accepted by our team will go to Nepal, our team is going to Bangladesh, and yesterday these Dubai people were also we want a physical presentation of this module. That really shows that everybody is in the need of the knowledge, and that is the thing. You people can also come, and we are really proud that Vanita and Dr. Mohammed Salman, you are really accepting us the branch and nurturing this branch, and credit definitely goes to our Ranjan Pizawar also, who is always there. So I wish all the best. Let's go ahead, go for exchange of the knowledge. Our basic aim is to serve our children, community, and our colleagues. So by exchanging our knowledge, we can serve all the three: children by giving them the best service, our colleagues, we can help exchange our knowledge, and country definitely. And by this all, we are going to help serve our country and community. So with this word, I once again want to thanks team American AMH IAP Bahrain, and along with today's speaker. Thank you.
Thank you,
Vanita?
Dr. Vasant. Dr. Neelam, could you also
Yeah.
join in?
Yeah, good evening. It's a pleasure and honor to be here today on this second webinar, which is being done of Central IAP India in association with its branch IAP Bahrain, with Vanita Jagannath being the president of it, and Mohammed Salman as the president of the IAP American Mission Hospital. The very fact that more than 200 people have gathered speaks volume of us pediatricians, where we believe in continuous learning, because it is through learning that we embrace knowledge and skills, and we will be able to improve our clinical performance. We are collaborating, that improves the care that we deliver. Ultimately, the aim is to be advocating for children health because we need to look into the rights and the well-being of children at large in all spheres of life across our borders in the world. Knowledge is something which surprisingly increases on sharing and spreading rather than reducing. With that, we need to understand that once this through webinars, though we have experts deliberating, we can understand what needs to be shared, and through this knowledge, we will move forward. It is indeed a pleasure that as the president-elect, I would support the efforts taken by our predecessors, Dr. Baswaraja and Dr. Vasant Kalatkar, in this wheel to work for children across the globe at large. Thank you for this opportunity, Vanit.
Thank you, Dr. Vasant and Dr. Neelam. That was nice and encouraging of you both. And looking forward for a good and encouraging next 2 years in pediatrics and with IAP. Whilst we proceed, I would like to introduce some of our colleagues and our background soldiers who made this happen. Dr. Mohammed Salman, of course, you all are aware, he is the IAP-AMH president, who is the liaison person for Bahrain and Middle East expertise as well as delegates. And Mr. Joel and Ms. Salma, they have been instrumental in getting CME accreditation as well as processing and marketing. Okay, with this, I would like to proceed with the CME event. As I already introduced, just prior to this, big thanks to Dr. Ranjan Pejawar, who has been the international licensed person, who is the background person who's made possible resourcing us with IAP expertise, as well as coordinating with us with the CME planning for the next 6 months. And Dr. Ranjan Pejawar wouldn't be available today because he's at present moment traveling also. He has sent us apologies. Okay, let us proceed with today's CME. As I already introduced, today's topic would be in pediatric nephrology. Our first speaker, both the topics are designed to complement each other and to inform the academic pediatricians who are part of the delegates, as well as the practicing pediatricians, as to how to be involved in the process of one common encounter, which is certainly ominous if not detected on time: chronic kidney disease. I tried looking into the statistics and its impact, the global impact and the impact in our region. Couldn't really get much of Bahrain statistics in pediatric CKD. Nevertheless, interestingly, I saw some information that one of the Kidney International statistics, which said amongst the countries which avails treatment relevant to CKD, Bahrain tops the region. I would share the paper much later and let the speaker make some useful information on that aspect. And a couple of other studies we gathered. One interesting study over 12 years about prevalence and epidemiology of CKD happens to say that it is as akin to the global epidemiology. And more interestingly, another study in the same region, Israel, says 10% more than actual detected CKD is in the stage 1, the latent one. And this is where we can make a difference if we happen to screen them earlier and happen to deliver it to the right resource person who can deal with it in a place, maybe in the new modern interventions, as well as technology like molecular genetics and nephroprotective resources, which would be interesting to listen to from our first speaker. Our second speaker, we all know most CKD would not be complete without assistance from radiology. So we happen to design a complementary topic from another specialist who is a consultant radiologist from Bahrain. So let me introduce the first speaker. This is Dr. Anil Vasudevan, is professor and in Department of Nephrology from St. John's Medical College Hospital, Bangalore. And he's adjunct professor, Division of Molecular Medicine, St. John's Research Institute, Bangalore. He has served various roles in the capacity of decision making and research. And he's a clinician researcher with interest in genetics and molecular basis of kidney diseases. So he's been in the editorial board of Nephrology, the official journal of Asian Pacific Society of Nephrology, and has various accolades and various articles that he has authored in the same capacity. So I would like to open the podium of Zoom for Dr. Anil Vasudevan to get started with the topic, prevention of role of pediatrician in prevention of CKD, recognizing the importance of the pivotal role of us pediatrician in this aspect. Dr. Anil Vasudevan, the next 30 minutes would be yours to enlighten us about the topic. Dr. Anil Vasudevan, please take the floor.
Thank you, Dr. Jagannathan, for your kind introduction. At the outset, as I share the screen, I'd like to thank the executives from the IAP, Dr. Karatkar, Dr. Mohan, Dr. Pejawa, for their kind invite and including me in this interesting monthly webinar series. Glad to know of the outreach program of the IAP. I'd like to also thank the kind host for today's webinar, Dr. Mohammed and Dr. Jagannath, for your participation, and also greetings to all those who have joined for today's webinar. So I'm going to spend next 30 minutes on early detection of kidney disease in a primary care and the important role that pediatrician plays. Chronic kidney disease in children is probably an under-recognized problem. The burden of which is not known, not just as Dr. Jagannath pointed out in Middle East, Bahrain, but even in India, we do not have a solid data to know what's the prevalence of this problem. But what I can definitely say is that it is being increasingly recognized etiology or a problem in children. Challenge primarily are three-faced. One is that there's a heterogeneous cause of an underlying CKD, and even more extreme variable presentation of kidney disease in children. And also the assessment of kidney function is age dependent. So clearly there are challenges that we need to face while diagnosing a child with kidney disease. So I'm going to start with defining what is chronic kidney disease and the common causes in children, the challenges that we face in a clinical setting to diagnose a kidney disease, and also using some case-based scenarios to highlight how we could diagnose these children with various forms of kidney diseases. I usually like this interactive, but because of the nature of the webinar, this will be a didactic, but I'm happy to take questions at the end of it. So a chronic kidney disease is abnormality in the structure or function of the kidney. Now, when I say function, it does not necessarily always mean the glomerular filtration rate. Because we can diagnose a CKD even with a normal GFR. Further, the severity of chronic kidney disease is staged based on the glomerular filtration rate and the extent of albuminuria. Just to make it simple, because I want to highlight just two important points. One is that typically in adult or in literature, you find that a CKD is generally diagnosed when the GFR falls less than 60 ml per minute, per 1.73 meters square. But that is not applicable in children. We need to diagnose them early enough when the GFR is normal. And second is that this stratification of chronic kidney disease is only applicable for those who are more than 2 years of age, because the adult GFR is reached only by 2 years of age. And this entire classification is based on the adult GFR. Hence, in children who are less than 2 years of age, we need to use the age appropriate or month appropriate GFR as shown here. But an important point to stress is that CKD can be diagnosed even in those children who have a normal GFR. And what do we mean by abnormality in structure? It means, for example, a hypoplasidysplastic kidney, and the GFR is normal. The child is diagnosed as CKD stage 1. A child with a distal renal tubular acidosis who have hypokalemia, severe metabolic acidosis is a disturbance in the function of the kidney, and yet the child can have a normal GFR. When the GFR decreases and reaches approximately 15 ml per minute, it is called as kidney failure or end-stage kidney disease. Now, when we come to causes of kidney disease in children, chronic kidney disease in children, most of them turn out to be of genetic etiology, and they can be broadly binned into, as shown in this circular donut diagram, from the European registry, where more than 50% is of congenital anomaly of kidney and urinary tract. Then comes glomerular diseases such as nephrotic syndrome, which is now referred to as podocytopathies. Then you have cystic kidney disease and hemolytic uremic syndrome. This etiology is more or less reflected in an Indian setting, and I'm showing data from our CKD clinic, where most of the children who are diagnosed are belonging to the congenital anomaly of kidney and urinary tract, which itself is a very heterogeneous group, as I've listed here. The second most common is the glomerulopathies, followed by polycystic kidney disease and ciliopathies, and then comes the other disorders such as hemolytic uremic syndrome, vasculitis, and so on. What is important to note is that more than 6 to 10% of those diagnosed with CKD do not have a clear etiology, mainly because they are diagnosed very late. But there's a bias here because most of these patients have severe chronic kidney disease. And some of the kidney disease that we face in a clinical setting, such as renal tubular acidosis or diabetes insipidus, are probably underrepresented here. Now, why do we need to diagnose CKD early? That's because of two reasons. One is the morbidity associated with it. As the GFR decreases from a normal of 100 to probably 70, 60s, it starts affecting the other organ systems, especially the bones, the cardiovascular system, and it affects the growth and the development of the child. It results in hypertension and so on, which significantly affects the quality of life. And often a delayed diagnosis makes the morbidity worse. So, and a precious window is lost to reverse or minimize these morbidities. And as the CKD progresses and reaches the end-stage kidney disease, the only way the medications do not work, and only dialysis or kidney transplant are the life-saving treatment. And you can see here in the picture, you can see the kind of morbidities that are associated with CKD. Here, short stature, bony deformities, hypertension, and so on. And dialysis and transplant, particularly in the Indian scenario or a low middle income economy, is very expensive. And in our clinic, only 10 to 20% of those with severe kidney failure are able to receive dialysis or kidney transplant. Hence, it becomes very important for a timely identification. And who better can be than the primary care physicians, because they are often the first point of contact. And an early diagnosis helps not only in providing the appropriate management, also in retarding the progression of kidney disease and morbidity and significant morbidities. Now, what are the challenges in early detection of kidney disease? One, many of the anomalies are silent. For example, a UPGO obstruction, uretropelvic junction obstruction, or a hypodysplastic kidney can remain silent for a long time and can present in adolescence or young adulthood with kidney failure. Second, many of the kidney symptoms and signs are non-specific in the sense that there may be some growth retardation, there can be vomiting, or they can be just generalized weakness. It can be subtle. For example, the proteinuria may be mild, not to manifest any other clinical symptoms, which can be only identified by urinary testing. It can be an organ mimic, like, for example, severe anemia can be often misdiagnosed as some form of an hemoglobinopathy or something like related to the blood, and never thought of kidney as an etiology for that particular anemia. Similarly, with bony deformities and myopathies, which are often the uremic manifestations of a chronic kidney disease. Sometimes the whole clue to a kidney disease can be picked up right in utero in form of an abnormal antenatal scan, or in the early childhood, such as a history of urinary tract infection or a family history of young onset kidney disease in the extended family members, which are often not looked into when a child presents with a non-specific symptoms. Measuring blood pressure, because hypertension, unlike in adults, which is a cause of CKD, in children, it is mostly a manifestation of a chronic kidney disease, is not a routine clinical practice. The challenge also remains with interpreting the serum creatinine. Often the absolute values may be misleading. For example, a 0.8 serum creatinine in a 1-year-old child is abnormal, whereas it could be normal in an older child. Hence, we need to use the estimated GFR using the Schwartz formula. And also clues in the urine examination. So some RBCs, some protein in the urine, or a hypokalemia in a laboratory evaluation may be thought of a confounding illness. Maybe the child has presented with diarrhea or fever and may be attributed to that and never followed up, or because it's so mild, it may be ignored. So these are the challenges that we face in the diagnosis or early detection of chronic kidney disease in a clinical setting. And very importantly, a lack of awareness of the manifestations of the way their child can present, not only in the community among the parents and families, but also among the primary caregivers. And also, unfortunately, some myths about chronic kidney disease that what do you do when you diagnose? Anyway, they'll need dialysis, transplant, which most of them cannot afford. Makes it a little more, an unfortunate fact. But fortunately, the awareness is increasing, and the diagnosis of chronic kidney disease is much better than what was before. Now, when you come to a symptomatology and signs of kidney disease, we can bin it into a specific and non-specific. Specifics such as edema, oliguria, gross hematuria, blood pressure, which is recorded as high, significant proteinuria. All this can be easily identified or correlated with kidneys as manifestation of a kidney disease, and they typically are seen in glomerular diseases. On the other hand, tubular diseases may present with polyuria without polydipsia, nocturia, which means waking up in the night to pass urine, bladder symptoms such as urgency, incontinence, or pain in the abdomen, passing stones, and these are all manifestations of a tubular interstitial disease. Some of these kidney-specific symptoms, such as polyuria, nocturia, can be difficult unless the patient, complains of it. More challenging are the non-specific symptoms, such as failure to thrive, recurrent fever without focus, symptoms of hypertension such as headache, electrolyte and acid-base abnormalities such as hypokalemia, hyponatremia, acidosis or alkalosis, bony deformities, easy fractures, and some of the uremic manifestation. When the GFR decreases significantly, they may present with myopathy, severe anemia, and non-specific uremic symptoms such as nausea, poor appetite, and sleep patterns. And many a times, a kidney disease could be a part of the syndrome, where the syndromic manifestations are much more severe or more obvious as compared to the kidney manifestations. And often, because of these reasons, they are referred from other specialties. Like we have had referral from cardiologists, we had a referral from neurologists, where mistakenly the uremic myopathy has been referred to neurologists as some unknown myopathy. We don't need a lot of investigations to diagnose kidney disease. We need a simple urine analysis and a urine protein albumin or albumin to creatinine ratio, kidney function test that includes blood urea, creatinine, serum electrolyte, plasma bicarbonate, calcium phosphate, hemoglobin, and an imaging ultrasound of the kidney and urinary tract. This is the basic investigation that we require to identify a kidney disease. I'll highlight only two aspects of this investigation because we have a follow-up talk. We have a case, I'm presenting a case scenario. A 2-year-old child with pneumonia and respiratory distress is admitted in the hospital. As part of the routine investigations, sometimes it is not done, but if it is done, it is good. Here, the child had a creatinine at admission of 0.8. My question is the serum creatinine normal for the child? So one thing we need to understand, as you can see, the lab here, it was referred from elsewhere. The lab here was even calculated an estimated GFR. They're given a range here. Now, can we say this creatinine is normal? So in order to interpret a serum creatinine, there are two important things that we need to know. One is that that the creatinine needs to be measured by a very standardized assay, a modified Jaffe or kinetic, and that need to be connected to the isotope dilution mass spectrometry. That is very important. Second is we need to estimate the GFR using the modified Schwartz formula as given in the formula here. And when you use this formula, we get that the GFR in a 2-year-old child is 42, in this child is 42.3 ml, which is clearly low because we expect the GFR to be at least 100 ml. So clearly this child has a kidney dysfunction, whether it's acute or chronic, we need some further evaluation. More recently, a newer formula called the CKD in children under 25 using serum creatinine and cystatin C has been used, but in most of the countries, we continue to rely on modified Schwartz. Sorry, summaries.
Request the audience to mute themselves.
And coming to urine examination, it's very important to have a appropriate interpretation is very dependent on an appropriately collected sample, which should be midstream and not from a nappy or which is squeezed into the collection tube or in a container and then poured into the collection tube vial. And that urine should be promptly examined. Otherwise, the results can be misleading. Sometimes a mild proteinuria, a microscopic hematuria, or presence of a few pus cells or WBCs in the urine could be transient, but we need to do a follow-up urine examination. Similarly, crystals such as uric acid crystals, oxalate crystals may be found in healthy individuals, and we need a good clinical correlation to interpret that finding. Now, in a detection of a disease, not just chronic kidney disease, it is important to identify those at risk for chronic kidney disease. So children who are born premature, that is less than 37 weeks, low birth weight, those who have a single kidney, acute kidney injury survivors, chronic diseases of other systems such as a lupus or a chronic liver disease or a cardiac disease, malignancy, history of taking NSAIDs such as in rheumatoid arthritis or a connective tissue disease, obesity. These are all risk factors for kidney disease. I'm not going through this in detail, but they are at risk because of a concept called nephron endowment. Normally, we have 1 million nephron in each kidneys, but in these group of children, either because of developmental anomaly, the nephron numbers are suboptimal. Hence, they have to function more than what a normal kidney would do, which results in hyperfiltration injury, which can manifest as hypertension, proteinuria, or a decline in GFR. Further, not detecting these clinical issues, a delay may further hasten the injury, plus additional insults such as use of nephrotoxic medications, urinary tract infections can further accelerate the decrease in the GFR. So it is important to identify those at risk for chronic kidney disease, especially those who are born preterm. We need to know that at a high risk. As you can see here, there's no low risk. They're either at a moderate or a very high risk, especially those are at very high risk if they have more than 2 risk events, such as an acute kidney injury, use of nephrotoxic medications, or having an underlying developmental anomaly. These children need to be followed up by the pediatrician with an annual blood pressure measurement, apart from the other routine management. And in those at high risk or very high risk, also need to have an urine analysis done to identify early, to detect proteinuria early. And also these premature infants need to be seen by a pediatric nephrologist either within 6 months in those who are at moderate risk, or during the NICU stay in those who are at very high risk, or within the 3 months of NICU discharge in those who are at high risk. It's very important to get an opinion from a subspecialist so who can advise the appropriate investigations and follow-up. So I'll give you a clinical scenario. Here, let's come to a few clinical scenarios just to highlight the importance of early detection. This was a child who had a normal birth weight, presented at 2 years, pain while passing urine in the past. Notice child had a low birth, was significantly malnourished and was short. The laboratory evaluation, no doubt, identified UTI and also a which is high, probably reflecting a kidney, the thickened bladder. And it was very surprising when the child presented with these manifestations at 2 years. Father produces an antenatal scan performed in the early gestation, which did show. Unfortunately, this is not followed up. So clearly, our job of early detection begins in antenatal period because, as you can see, perturbation in the normal development of the kidney and the urinary tract can result in a lot of various congenital anomalies of kidney and urinary tract. The second important point is that the amniotic fluid, the 90%, is fetal urine. So that also is an important marker of a underlying kidney disease. So in an antenatal ultrasound, presence of oligohydramnios, earlier it manifests, more likely to have a kidney etiology. Antenatal hydronephrosis, especially bilateral hydronephrosis, distended bladder, ureteral dilatation, cyst in the kidney, small or large kidneys, extrarenal signs such as ossified nasal bone, increased nuchal fold more than 4 millimeters are all flags for a possible underlying kidney disease. Very rarely, polyhydramnios or Bartter syndrome. Now, a good rule of thumb of a kidney size is that the kidney size should be equal to the gestational age. That could be used as a rule of thumb to know whether the kidney size in an antenatal scan is normal or not. And hence, a kidney ultrasonography, which this was done in the previous case, which I highlighted, was done after birth. It could have been identified early. So a postnatal scan is a must in those with an abnormal kidney and urinary tract in an antenatal scan. Similar, and also we can identify some other markers of kidney disease at birth, such as single umbilical artery, earlobe defect, which may result in a syndromic, Kakut, spinal and genital abnormality, which indicates probably an underlying neurogenic bladder and Kakut, and syndromic features such as Potter's facies and other syndromes, where many of the syndromes can have congenital anomalies of the kidney and urinary tract. Many times, the first manifestations of kidney disease does not mean necessarily a kidney symptom or a sign. It could be an extrarenal symptom. This is the data from a cohort from Europe of children with congenital anomaly of kidney and urinary tract, where they found that 30% of them had an abnormality in either the heart, hearing defect, ocular growth retardation, bone deformities, dysmorphisms, and so on. So if you find a child who is obese, has hypogonadism, like a Bartle beetle, has a coloboma in the eye, extra digits, abnormal thoracic, thorax or skeletal dysplasia, think of a potential underlying also of kidney disease that may coexist with the other, with the primary syndrome. And hence, a careful examination of children can identify a child with a kidney disease early. Coming to another scenario, this is a child who presented with fever and vomiting of 3 days. She had features of upper respiratory infection. This is how she looked. This is a 9-year-old child. This is taken with the permission of the family. And if I compare this child, this is a younger sibling who's 7-year-old. You can see this child has a significant short stature. And this child had a complaint of poor growth noticed since the age of 3 and 4 years. And that worsened along with appetite and weakness. Since last 1 year, she presented to us. She had reported to the primary care doctor and was given tonics because she was not growing well. And you can see that it was a significant short stature. The first serum creatinine that we recorded was very high. And this child ultimately turned out to be a child with primary bilateral hypodysplastic kidney and did not have any, was not associated with any syndrome. So clearly, failure to thrive or growth retardation is an important sign of underlying chronic kidney disease, and it can be seen in 3 contexts, either with tubular disorders such as RTA or Bartter syndrome, or as a primary manifestation of an underlying chronic kidney disease with a low GFR, or could be a part of a syndrome such as a Bacterial or a Fraser syndrome or other aneuploidies. So we need to suspect or consider a chronic kidney disease when there is an unexplained failure to thrive or failure to thrive with anemia, urinary tract symptoms, high blood pressure, UTI, or an abnormal antenatal scan. And in these children, these investigations are enough to identify whether the child has a CKD or not. Coming to the third case, this is a 4-year-old child, and notice that it was referred from an orthopedics department to us because of progressive bowing of legs noticed since 1.5 years of age. There's no polyuria, polydipsia. Examination revealed significant short stature and deformities of the lower limb as seen here. This child also had dental defects. On investigations, the urine was normal. The renal function, kidney functions were normal, but however, the child had a very low phosphate, high ALP, suggestive of some kind of a ricket-related illness, but the vitamin D was normal. There was significant phosphate wasting. The ultimate diagnosis here was an X-linked dominant hypophosphatemic ricket. But my message here is that a child with a bony deformities or diagnosed as rickets, think of a kidney cause if especially the onset of rickets is very young. There's significant disproportionate involvement of the lower limbs, no response to a conventional vitamin D treatment. They have unusual defects. There's an this can be never a feature of a nutritional rickets. Severe dental defects. This could be seen in hypophosphatemic rickets or in children with renal tubular acidosis who may have amelogenesis imperfecta. There can be significant alopecia in vitamin D dependent rickets. Growth retardation, as seen in Fanconi syndrome of cystinosis or Fanconi Bickel or Lowe. This child and some children also have cataract because of an underlying, which could be an underlying clue to the possible etiology. They may have polyuria, polydipsia, or in vitamin D dependent rickets, they often have hypocalcemia, which is disproportionate to the phosphate levels. Or may be present with seizures. Whenever you have these flags, think of a renal cause of rickets. And in them, you need to do these investigations to identify the possible cause of the rickets, which is often either a renal tubular acidosis or a hypophosphatemic rickets or a Bartter syndrome. So in any child, once you have excluded a nutritional cause of rickets, the serum phosphorus can be a big clue. A mimic of this rickets is a chronic of a bone mineral disease associated with CKD. In them, the phosphates are high. The kidney function is obviously abnormal. On the other hand, a child with a low or a normal phosphates, ABG and electrolytes can give a clue, such as in presence of acidosis, you think of a renal tubular acidosis. When the ABG is normal, a very low calcium, high PTH, you think of a vitamin D dependent ricket. But when the PTH is normal, calcium is normal, in the background of a very low phosphate, you think, and a normal vitamin D, you think of a hypophosphatemic rickets. This is a child who presented with easy fatiguability, looked pale on examination. She was short. There was no hepatosplenomegaly. She has received repeated blood transfusions in the past and was on iron supplements for a long time, but her anemia did not improve. And finally, with primary care, when they recorded her blood pressure, was recorded to be high and was hence referred. And when the child came to us, the hemoglobin was 6, had a normocytic normochromic anemia, and the serum creatinine was 4.8 milligram per deciliter. So clearly, a chronic anemia that is refractory to iron therapy, requirement of repeated blood transfusion without clear evidence of a hemoglobinopathy, you need to consider an underlying chronic kidney disease. Coming to the fifth clinical case, this is a 15-month-old child, very undernourished, who had frequent urination, increased intake of water noticed since 3 months of age. You can notice a lag after which the child was referred. There was no history of seizures or vomiting, but also there was a significant gross motor developmental delay. The child appeared dehydrated, had a typical triangular faces, no other evidence of rickets. On probing, the child was born a little preterm, and also the mother also did not have an antenatal scan report. And this is what an electrolyte parameter showed us: hyponatremia, hypokalemia, hypochloremia, alkalosis, and kidney function test. The urine was bland. The ultrasound showed nephrocalcinosis. Clearly, there's no, it's a clear diagnosis of a Bartter syndrome, which we confirmed on genetic testing. Again, here, the point of highlighting this case is that many often the child has history of polyuria, but it's a very difficult history to pick up or attribute significance to, because and how do you take this history of polyuria? Because it can be age dependent. For example, the mother may complain of soaked nappies, a primary enuresis or a toilet train difficulty in an older child, in a young child, and in an older child, they may present with nocturia. But in a child with a history of polyuria, polydipsia is an important flag, and this complaint can be very indirect. Either irritability or crying soon after feeds in an infant. They prefer liquid over solid. They have a fluid-seeking behaviors like drinking from toilet taps in neighbor's house because they're so thirsty. The teachers may complain that this child is using the toilet very frequently. And in this situation, we also have to always attempt to get an estimated amount the child drinks. Second is a history of polyuria, the failure to thrive is again a flag. But we have to note that often these children with tuberous acidosis, unless it's very severe barter, have a normal appetite. That's unlike in a child with who's of malnutrition. Here, the appetite may be normal to a significant extent. There may be history of vomiting and tachypnea because of the acidosis, constipation because of the hypokalemia, and often they are admitted with dehydration, where the underlying cause is trivial, maybe few episodes of vomiting or diarrhea results in a significant dehydration. In fact, a big clue in these children are that these children maintain normal urine output despite severe dehydration. Any child who's severely dehydrated or moderately dehydrated has normal or more than normal urine output, think of an underlying tubular cause of kidney disease. They may have disproportionate gross motor delay because of the associated loss of phosphates and vitamin D related issues. They can have bony deformities, deafness in case of distal renal tubular acidosis, and some form of Bartter syndrome. Symptoms of hypertension if they have a reflex dysplasia or UTI. And often these children may have clues in the antenatal and birth history, that extreme preterm, they had severe hyponatremia in the early neonatal period. And they may also have history where the siblings or the cousins are diagnosed with some undiagnosed kidney diseases. These are often clues. And when these are present in a history of polyuria, think of a chronic kidney disease. And most of the time, they are either a renal tubular acidosis, Bartter syndrome, or a diabetes insipidus. And they can also be important to identify other transient causes of polyuria, but that is not, we cannot discuss it here. But I want to again also highlight is that that frequency of urination is not always that a child is passing a lot of urine. We need to distill the mimics in order to identify the cause. For example, those about 3 years of age can be seen in an underlying nephronophthisis or obstructive uropathy. A secondary nephral aneurysm is because it could be another organ or some psychological issue. Frequency of urination with other lower urinary tract symptoms such as urgency, poor urinary stream, bladder, urine postponing maneuvers. We always think neurogenic bladder, those manifestations. So whenever you go to measure the volume of urine in older children, or at least in infants and neonates. Hypertension is the most common etiology. The most common hypertension is kidney disease in children. So my question is, a 5-year-old girl comes to your clinic for booster immunization. Will you measure blood pressure in this child? 3-year-olds or older, we need to measure the blood pressure at least once during healthcare episode. But those children who are less than 3 years of age has history of prematurity, recurrent UTI, known kidney disease, or organ transplant, malignancy, or some other systemic manifestation, we need to measure their blood pressure also. But what is important is that we need to measure it correctly using an appropriate size cuff. We can use the tabletop or use an auscultatory method, but we need to repeat the measurements a couple of times before we confirm that the blood pressure is high. Now, this is a good example of how a child with hypertension could present. This is a child who presented with an easy fatiguity and vomit, referred to an Cardiology Institute because the child had breathlessness, on evaluation had frank symptoms of cardiac failure. And you can see the note, the evaluation done in the cardiology, the ECG was abnormal, the echo was completely abnormal. But when the blood pressure was measured, the blood pressure was very high. And when the child came to us, we also looked at the fundus, which showed papilledema. Just cutting the story short, this child had a high creatinine, an ultrasound where the kidney size was 8.3 and 6.1. You can notice that the right kidney was smaller as compared to the left. And on evaluation was found to have bilateral severe form of vesico-ureteric reflex. And the DMSS scan showed that the right kidney was not at all functioning, and on the other hand, the left kidney had many scars. So we need to be aware of unusual presentation who's seizing, who has blood pressure. UTI is an often discussed topic. I will not spend much time here, but I want to highlight that we need to have a low index of a high index of suspicion, especially when there is a fever without focus. And also we need to remember that the UTI symptoms may be very non-specific in young children and newborns. And it, and also sometimes in older children. So it needs a high index of suspicion to diagnose UTI. Why is the diagnosis of UTI important? Because a significant proportion of them may have an underlying kidney disease. So in a child with UTI, it's a high likely to have a kidney disease if the examination reveals, a palpable bladder or a kidney, the spine reveals, a tuft of hair, a sinus, or a mass, such as this. There is an ambiguous genitalia or a severe phimosis, can be an indirect marker of a urogenital anomaly along with kidney disease. An abnormal ultrasound, such as a small kidney size, abnormal parenchyma, or hydronephrosis, again is a flag. Atypical UTI,
Hello.
this is very important. If a young child is presenting with urosepsis or has a poor urinary stream, abdominal mass, also has a high creatinine at the time of a diagnosis of UTI, if there is no response to an antibiotic within 72 hours, or has a non-E. coli infection, evaluate for an underlying kidney disease. In addition, any child presenting more than once with UTI, even in them, if they don't have any other manifestations, please do investigate for underlying chronic kidney disease. Most likely is going to be an congenital anomaly such as hypodysplastic reflux or a neurogenic bladder. Lastly, apart from the child, it is very important also to pay attention to the family history of consanguinity, and also screen the siblings. I will give you two examples, and this is my last slide. This is a child whom we diagnosed as autosomal recessive polycystic kidney disease. Genetic testing could not be done because the family could not afford it. However, we told them because of the consanguinity that the child, if you're planning pregnancy, please inform us the antenatal scan report that is done in the early gestation. And in this fetal scan, what was noticed was a bilateral raised echogenicity of the kidney, and it was a little larger, indicating that this fetus also had a possible ARPKD, and this helped us to counsel them appropriately. Similarly, in this 7-year-old child who presented with poor growth, repeated episodes of pain abdomen and UTI, finally, imaging showed nephrocalcinosis, and the urinary analysis and all the other animals confirmed a primary hyperoxaluria. This is an MRI image. We don't routinely do it, but this was done because the child presented once with an obstructive AKI. You can see the dense nephrocalcinosis and stones here. So because of, again, consanguinity and a genetic form identified as a cause of primary hyperoxaluria, the child had an older brother. Although the family denied any complaints, we just asked them to screen to bring the child for just a basic screening. And here in the ultrasound, we could already notice that this older brother also had some evidence of nephrocalcinosis and early onset of hyperoxaluria. Although possibly he has the same genetic defect, the presentation was completely different. One was asymptomatic, the other one presented very early. But I just wanted to highlight the importance of screening siblings and also the family history and history of consanguinity. So in conclusion, to Diagnose CKD early. We need to have a high index of suspicion. Any unexplained non-specific symptoms, syndromic features, do consider kidney disease. If other etiologies are ruled out, always do a follow-up renal ultrasound after birth in those with antenatal hydronephrosis, irrespective of the severity of dilatation, and also in any antenatal scan that has unexplained oligohydramnios. Make blood pressure measurement a part of the routine office practice. A thorough history and examination on all children presenting with UTI is very important to detect an underlying CKD. And those who are born low birth weight and preterm, those with single kidney need follow-up for protecting their kidney health. Thank you for listening. I leave you with few images of our attempt to reach out to the community in various forms, in such as street plays, exhibitions, to highlight how kidney disease can manifest in children, to increase the awareness among the public, and also to let you all know that on 13 March is being celebrated as a World Kidney Day with the theme kidneys. Okay, thank you.
Thank you, Dr. Anil. That was 30 minutes packed with a lot of information, a lot of realization where we belong as to early diagnosis and how we can make a difference in early diagnosis. So to identify ourselves, we can make more discussion, and the case scenarios which you portrayed are quite interesting to weave our discussion over, unless some people have some more interesting scenarios. Dr. Ranjan always says in any discussion, all problems begin in the womb. So noticing the nephron endowment during the preterm and then the impact of that in the later CKD and extending it to CKD in adulthood, we have a good role there to make early diagnosis. So gathering on the points Dr. Anil made on how we can make a difference in this CKD diagnosis. And it seems like we play a pivotal role. Unless we diagnose and send it to their zone, it probably would be missing the bus. So we should be proactive in screening. That would be the primary role in prevention of CKD. Now I'll open the floor to our next speaker before we have a discussion on the topic. Dr. Anil will come back to you after the next speaker. So the next speaker is Dr. Tejal Shah. She is our consultant radiologist in American Mission Hospital, King Hamad American Mission Hospital. She has completed a diagnostic radiology residency in India. She's done specialized training in Apollo hospitals for years to follow, as well as done body imaging fellowship in University of California, San Diego. She has been a consultant radiologist for several years after this in Salmania Medical College, which is the National Institute of Medicine in Bahrain. And after which she's serving as the consultant radiology with us in King Hamad American Mission Hospital. We noticed that the radiologist has a good role to play in complementing the early diagnosis of CKD, and wherever the role of a radiologist and a pediatrician, when to count on a radiologist, will be an ideal complementing discussion. So we would have this discussion. I think the landscape has changed on this matter, adding molecular genetics also, but we will focus on radiology and then get back to Dr. Anil regards molecular genetics in CKD. So Dr. Tejal, we will open the floor to you to get started with the continuation of the discussion, pediatric radiology in the scene of CKD or nephrology. Thank you.
Dr. Vanita, for your kind introduction. First of all, I would like to thank Indian Academy of Pediatric for giving me opportunity to be part of this excellent academic fest. And special thanks to Dr. Muhammad and Dr. Vanita to invite me for participating in this discussion related to the pediatric nephrology and the role of imaging in pediatric nephrology. So next few minutes, I'm going to discuss about the role of imaging in pediatric nephrology, and particularly to point out the role of imaging which can lead and enhancing the prevention leading to the CKD or end-stage renal disease. So all of we noticed that in the imaging modalities, last few decades has really progressed rapidly for being in apart from the standard modalities, some new modalities have also emerged, and overall the radiology has given a good impact in diagnosing the renal and urinary tract abnormalities. So as we know that general pediatrician and neonatologists are the frontline who are main physicians or clinicians to detect this renal abnormality and then taking it forward for the next level to detect it, those symptoms related things to finalize their diagnosis, and then taking it further forward to how to delay the progress into the chronic kidney disease. So knowledge of the applicability, indications, and nephrotoxic risk are equally important for each modality to understand. And depending on that, it is equally important that right investigation to be chosen from the clinical side also. So we all know that congenital anomaly of the kidney disease and urinary tract are the major factor, or it is contributing over 50% of the pediatric CKD cases. So it is important to consider the maldevelopment of the collecting system as these, because their functional interaction always during the fetal life determines the severity of the disease and the rate of the CKD progression. So it's equally important, as Dr. Vasudevan has also mentioned in his talk, that the antenatal detection is very important in these cases, followed by the postnatal period of the imaging. So next few minutes, I'm going to discuss about the various standard imaging modalities. They are related to the anatomical modalities or functional modalities with its advantage and limitations, newer imaging modalities in the radiology, various abnormality and the role of imaging to detect it, and then impact of the imaging in the detection and ultimately to prevent or slow down the process of the end-stage renal disease or related complication. So imaging modality, we all know that it's standard imaging modality, and one of the best modality for the pediatric population is the ultrasound. And the standard grayscale ultrasound is one of the primary modality for the pediatric population to detect any abnormality. Followed by voiding cystourethrogram, then CT scan, MRI, and functional imaging are playing the equal role related to the nuclear scan, where the different tracers are being used, and depending on that, the DMSA scan or MEC3 scan or DTPA scan can be performed to look for the function of the kidney. So ultrasound, we all know that it's a gold standard for the pediatric population, first line modality for the evaluation because of its definitely major advantage of non-invasive, broadly available, fast. Definitely ionizing radiation is the major cause why we are choosing the ultrasound, to avoid as far as possible to give the radiation to the children. It is most cost effective and does not require any specific position or machine to be kept, the children to be kept inside. What information usually get by the ultrasound is the kidney size, its ecotexture, parenchymal thickness, symptoms, the information related to the chalazial system and the dilatation of the chalazial system and ureters. We can identify the mass in the large calculi, measure pre and post-void bladder volume, and it is equally important to it provides the real-time actually image for the guidance of interventional procedure whenever it is required to intervene by it. Voiding cystourethropy is a gold standard when it comes to the diagnosis of the vesico-ureteral reflux, which is one of the very common cause leading to CKD. The grading of UR is mainly depending on the modality of the voiding cystourethrogram. By using, we all know how to do it, and I'm not going into the detail of it. Okay, now next comes to the CT scan. So after using the primary modality as an ultrasound, as and when required, when we come to the conclusion that, okay, these are some of the abnormality and the ultrasound is not enough to go further or to take the further decision, CT scan has a role. It has a high anatomic definition and it provides a good panoramic view. It is less preferred because of the radiation exposure, but whenever it is required to go for some of the complex etiology and to diagnose the better anatomical definition, we need to go for the CT scan. For the CT angiography, it is important when to evaluate about the suspected renovascular hypertension, and a contrast excision CT urography plays an important role where and useful to detect the evaluation in the case of the trauma or suspected urinary tract obstruction or chalazial diverticuli. MRI provides a good anatomical information without radiation, but the limitations are it is costly, longer time of the study, and needs sedation in the younger child, particularly if they are less younger than the 7 years. So those are the limitation of the MRI, but it definitely provides a good anatomical information without radiation. Next comes to the functional imaging, where the functional renogram is an important part of the imaging in the pediatric renal abnormalities, where it is functional renal scans which follow the uptake and excretion of the radiotracers through the kidneys and into the collecting system. So the furosemide renography or scintigraphy or renal scintigraphy can be used as a part of the evaluation as a functional imaging by the radionuclear scan. Now let's see some of the newer emerging modalities. Some of the Western countries have started using these new modalities, which are 3-dimensional ultrasound and ultrasound elastography, contrast enhanced ultrasound, contrast enhanced voiding urosonography, 3D printing, and functional MR urogram. These are the emerging modality which have started developing in because mainly to avoid the radiation. So ultrasound guided procedure like the contrast enhanced ultrasound and contrast enhanced voiding urosonography is greatly emerging nowadays to avoid the radiation, to look for the standard voiding cystourethrogram. In some of the cases, you might have to undergo this modality very frequently. So these are the modality which are coming up with the quite a promisable evaluation in the case of the congenital anomalies related to the kidneys and the urinary tract. So 3-dimensional ultrasound has a very clearer and sharper ultrasound image. It gives the better reconstructive analysis of the anatomy, and it is better tissue differentiation can be seen through it. It provides the volumetric evaluation and complete visualization of the collecting system. And it because the one single sweep can finish the study, and then later on we can do the reconstruction in the multiple planes depending on the kind of the anomalies we are dealing with. It is comparable to those of the scintigraphy and the MR urography, and emergence can result in the decrease in the future for the use of the computer tomography and the diuretic renography. Ultrasound elastography is another advanced technology where it is related to detecting this tissue stiffness, and nowadays it is broadly used in detection of the certain anomalies, abnormality of the liver, thyroid, breast, and the prostate. But recently it has started to implement on the kidney disease to measure the fibrosis, particularly the cases where the ARPKD, like cases where you need to measure the hypergenicity kidneys with the fibrosis involved in those disease. Contrast enhanced ultrasound is one of the non-invasive kind of the study where the microbubbles are used for the intravenous contrast agent as a contrast agent, and this kind of study is more useful for detection of the perfusion abnormality, especially in the post-transplant patients where the detection of the perfusion abnormality is very important to detect as early as possible. So this is one of the case where the younger pediatric patient who has undergone the kidney transplantation and followed by the contrast enhanced study which shows the poor perfusion in the lower pole region. Contrast enhanced voiding urosonography is also another study which is radiation free and gives the good alternative to the standard voiding cystourethrogram. But the limitation so far is that it has more value when it is used for the high grade reflux rather than the low grade reflux. So some limited evaluation is going for this particular study. This is one of the image which shows the two images of the same patient where the standard voiding cystourethrogram was done for the high grade reflux, and the another image is showing the contrast enhanced urosonogram, which shows the reflux of the contrast into the collecting system. 3D printing is upcoming a new modality where the Radiology of Society of the North America has launched a program on the 3D printing, which shows the good morphology in certain cases where the complex anatomy is involved, as well as some tumor related issues are involved, which gives the good anatomical explanation by the models by the 3D printing, and that gives good understanding to the surgeons, trainees, and the patients and their families. So as the technology expands, it is going to become a more broadly available, and it may become the standard of care, especially in the complex anatomical cases. Functional MR urography provides comprehensive morphological and functional evaluation, and it's greatly coming up and emerging nowadays. It depicts the detailed anatomy of the genitourinary system and serving as a pre-surgical map for the high level of confidence to provide the 3D reconstruction. As a part of the protocol, patients receive the IV hydration and diuretics, and as a part of the functional part of the study, the gadolinium-based contrast agent is administered, and images are acquired dynamically over the period of time, and which is followed by up to 20 minutes, and that can analyze the functional part of the urinary tract system. So this is one of the example where you can see the different phase of the functional MR urogram, where the standard T2 phase, which shows the normal kidney on the right side, and the left side there is a duplex system where the lower moiety is showing the dilated system. The post-contrast dynamic study with the early arterial phase showing the enhancement of the renal arteries in the same phase as the aorta, followed by the 5-minute images and the 15-minute images, which shows the normal contrast enhancement excretion in the normal right kidney as well as the upper moiety on the left side, while the lower moiety does not show any excretion of the contrast, suggesting the obstructed moiety. So now coming to the major part of the imaging part, which is responsible for the leading cause of the CKD, which is the congenital anomalies of the kidney and urinary tract, which is known as the CACUT. These are the abnormalities which can be detected as early as possible, and which can prevent the delayed the leading cause of the CKD. This congenital form or CACUT is having the wide range of abnormality ranging from the asymptomatic ectopic kidneys to the life-threatening renal agenesis, and which is classified mainly on the embryological basis, which are mainly 3 divisions: abnormality related to renal parenchymal development, embryonic migration related abnormality, and abnormality of the collecting system. Ultrasound, computer tomography, and MRI are the major standard modalities to detect these abnormalities. Why it is so important to detect? Because timely diagnosis is crucial in selected abnormalities. It is useful to minimize the renal damage. It prevents or delay the onset of the end-stage renal disease and provides supportive care to avoid the complication of USRD. As per the North American Pediatric Renal Trials and Collaborative Studies, up to 30 to 50% of the ESRD related to the congenital anomalies of the kidney and urinary tract is related to it, and hence it is very crucial to diagnose for not only diagnose, but the management depends on the early diagnosis. These are the division of the all the 3 division of the different CACUT related abnormalities. Diagrammatically divided as per the upper urinary tract part, where you can have a renal agenesis, dysplasia, cystic kidney disease, horseshoe or cross-fused renal ectopia, and uretropelvic junction stenosis or ureteral duplication, uretrocele, and the lower tract related to the Hutch diverticulum, urachal diverticulum, or posterior urethral valve. as Dr. Vasudevan has clearly mentioned, it is equally important to give the precise evaluation during the antenatal screening ultrasonography. Antenatal scan is very important in the demonstration of the fetal kidneys, urinary bladder from the early second trimester level. It helps to detect the number of major congenital anomalies of the urinary system. It consists of the assessment of the presence, location, size of both kidney and evaluation of their structure and echogenicity. Evaluation of the fetal bladder, external genitalia, and amount of the amniotic fluid is equally important in that particular part of the sonography. Abnormalities detected in antenatal ultrasound that includes the hydronephrosis, hydroureter, thickened bladder, cystic kidney, small or dysplastic kidney, and absent kidney. So antenatal detection of the renal abnormalities that warrants the postnatal physical examination and postnatal renal ultrasound soon after the birth and again at the 4 to 6 week of the age is very important for following up these kind of the abnormalities. So when we go for the renal parenchymal malformation, there are few things which leads to the diagnosis related to that, and ultrasound as an important modality. So renal agenesis can be a complete or one or the both kidneys can be there. Bilateral agenesis definitely is incompatible with the life. And unilateral can be often asymptomatic and usually it presents or detected accidentally when it is the ultrasound or some of the other modality can be used for detection for some other abnormality. So you can see sometimes as a compensatory hypertrophy of the other kidney, which can be a cause of actually the glomerulosclerosis in the adult life also. Ultrasound, we are seeing the absent kidney in one side and compensatory hypertrophy on the other side. The most important part when we detect it as an antenatal part in the early second trimester, where both the sides you see the absent kidney, which is showing the lying down adrenal signs where the adrenal glands are flattened in the absence of the kidneys. It can be associated with the other abnormality like the ipsilateral seminal vesicle cyst, which is seen in this case with the right-sided agenesis of the kidney, and in the female sometimes it can be associated with the uterine didelphys. Supernumerary kidney can be present as one or more accessory kidney and can be smaller in size with the reduced function also. It is equally remembered to make sure that some of the abnormality of the shape, like a persistent lobulation, hypertrophied column of Burton, and dromedary hump are the variation and should not be considered as a mass or the other abnormality. Renal hypoplasia is a congenital small kidney with a less number of the papilla or chalazial system and can be detected often on the accidentally, where you can find a smaller size of the one kidney, which has a normal, which can be normal function, or it can show the mildly reduced function too. Renal dysplasia, multicystic disease of the kidney is one of the major cause, and it is a developmental disorder, major developmental disorder of the kidney, where the antenatal and postnatal ultrasound is most diagnostic form of the modality to detect it, which shows usually multiple cysts which are not communicating to each other, while the polycystic kidney will have a different multiple larger cyst on the other hand. DMSA scan is useful in this kind of anomalies, which it is important to establish the non-functioning kidney in this kind of abnormality. Reflux is major, one of the frequent and abnormality associated with this kind of the dysplasia. So where ultrasound shows the multiple cysts of the varying sizes in the affected kidney with the contour abnormality, while the other kidney can be of the normal size and characteristic. This is another case of the multicystic disease with the larger cyst and the other kidney was normal. It can be sometimes detect for some other reason when the fetal MRI was performed, and or particularly for this reason, fetal MRI can be done in the late second trimester, where it can be detected as a multicystic disease of the kidney. Autosomal dominant polycystic kidney and ARPKD also are important. Usually ADPKD are diagnosed in the adult life and not diagnosed early in the childhood cases, while the ARPKD is infantile form is most prominent form of the renal involvement, where the kidneys are bulky, hyperechogenic, on the ultrasound, and it shows reduced corticomedullary differentiation. In the perinatal type, it is most common, which can be presented as an oligohydramnios or pulmonary hypoplasia. So the kidneys appears usually enlarged and echogenic, but it retains usually the reniform, its normal shape. So in this case, that was diagnosed as an IAP-KD, which shows the echogenic kidney with multiple small kidneys. Abnormal migration is another type of the abnormality which includes the ectopic kidneys. The ectopic kidney or the cross-fuse ectopia are the common malformation on this kind of thing, which can, in this scenario, the kidney can present in a different location, either in the pelvic, which is most common, or in the abdominal, or sometimes rarely in the chest also. If it is present in the abdomen, USG can be a diagnostic modality, but the cross-sectional imaging plays an important role to look for the final anatomical configuration or place of the kidney, and sometimes the CT urography gives the proper diagnosis with the detailed evaluation. Cross-renal ectopia is another form of the malformation where the fusion of the lower pole of the orthotopic kidney to the upper pole of the crossed ectopic kidney. And it can be associated with the other genitourinary malformation. And usually they are sometimes presented with the complication, stones, infection, or hypertension from the multiple anomalous arteries. CT urography plays an important role in confirming the diagnosis and demonstration of the collecting system, its arterial supply, and its complication. So this is one of the study where initial study was performed for some reason, and IVP study was showing the pelvic kidney, and CT was performed to finalize the diagnosis as a pelvic kidney in this case. CT plays an important role, as you see in this case with the 3D images, which shows the cross-fuse ectopia. Sometimes it can be accidentally detected when the study was performed for some other reason like this. In this case, the lumbar spine MRI was performed and cross-fuse ectopia was detected at the same time. DMSA scan is important to look for the function in this kind of cases, for the function of or split function in this case of cases. It usually is association of the multicystic dysplasia or patent ureteroceles or the other ectopic ureteral orifice, hyperspadiasis or PUG obstruction are the usual association with this kind of the malformation, and can be presented with a complication like hypertension, infection, or reflux. Horseshoe kidney is another kind of the malformation, which is, and the CT is the best modality to look for the anatomical configuration, and usually these are malrotated kidneys, so CT urography can be helpful in showing the full course of the ureter. If you want to look for the functional things, then DMSA scan is performed for this kind of the malformation. Now coming to the abnormal collecting system, the duplex collecting system is one of the most common congenital tract anomalies, and it can be an incomplete fusion of the upper and lower pole moieties, resulting in the variety of the complete or incomplete duplication. Sometimes USG ultrasound has a limited role in detecting the duplication, while the CT and MR urography plays a major role, and their modality of the choice help in demonstrating the detailed anatomy of the collecting system, the level of the fusion of the ureter, and status of the ureteric orifice, which can be present as a complication as a part of the VUR or obstruction or ureterocele. Usually the standard rule or the abnormality which we detect on this kind of abnormalities, the upper moiety often ends in the ureterocele with the obstruction, and lower moiety usually shows the vesico-ureteral reflux. Ectopic insertion of the upper moiety into the sometimes can be seen in the prostatic urethra in the males or vaginal wall in the females. So in this case, the imaging plays an important role to look for the ureteric orifice. And extraordinary urography plays the role for the poorly functioning system, which shows no expression of the contrast. CT scan delineate and the abnormality, which is important to delineate the whole course of the ureter, and nuclear medicine is done to basically it is helping in evaluating the renal function, and it's particularly useful in planning the corrective surgery. So this is the kind of IVP image which shows the duplex system with the water, the lower moiety shows the dropping lily sign, which is displaced inferiorly. And in the CT urography, it shows the bilateral duplex system with the ureter opening both up to the bilateral ureteric orifice in the bladder. Next coming up is the pelviureteric junction obstruction, which is one of the commonest cause of the antenatal hydronephrosis. So etiology can be extrinsic or intrinsic as a intrinsic part of the ureteral hypoplasia or high insertion of ureter, or extrinsic cause can be due to the ureter entrapment of the ureter by the crossing of the accessory renal vessel. It can be associated with the other malformation also. So always we should look for the other abnormality associated with the pelviureteric junction obstruction. The common final pathway is the difficulty of the urinary drainage, which leads to the pelvic and the renal dilatation and sometimes damage to the renal parenchyma, which is if it is not timely corrected. Antenatal and postnatal ultrasound are the most diagnostic tool which shows the disproportionately dilated renal pelvis with the mild dilatation of the calyces and non-dilated ureter in the antenatal scan. DTPA scan is useful to assess the degree of the obstruction and the split renal function. CT usually helpful in demonstrating the crossing the vessels in the later stage, and CT urography is more commonly used in the adult population rather than the pediatric population. MR urography is another modality which is coming up with the high evaluation related to the anatomical evaluation and without the radiation. So diuretic urography is one of the most important study which is used to determine the split function of each kidney and identify any renal. The kidney is considered damaged if the split function is one of the kidneys less than 40% of the total kidney function, and that should be in correlation with the half-life of the agent. This is the ultrasound, different grading of the ultrasound for the pelviureteric junction obstruction, starting from the mild dilatation of the renal pelvis to the significant dilatation of the renal pelvis, calyceal system, and thinning of the parenchyma. The Society of the Fetal Urology has developed a grading system to evaluate the severity of the hydronephrosis, and depending on that, the grades 0 to 4 gradings are developed, where the grade 4 is the most severe grade, which shows the severe dilatation of the renal pelvis and calyces with the accompanying parenchymal atrophy or thinning. Here we should keep in the mind that almost 20% of the antenatal detected hydronephrosis is not found after the birth. So it is equally important to follow this kind of the abnormality in the postnatal period immediately after birth and followed by 4 to 6 weeks after the birth. And different gradings have been developed apart from the SFU. The other grading system are the urinary tract dilatation developed in 2014, and ONAN system is also developed. But baseline for this grading system is that it depends on the dilatation of the pelvic-calyceal system and the thinning of the parenchyma. So this is one the young child, actually the 6-month-old girl with the UPJ obstruction in the initial scan was showing the dilatation of the pelvis and calyceal system with mild thinning, followed by another ultrasound done after the 2 months, which shows actually progressive increase, significant increase in the dilatation of the pelvic-calyceal system and the thinning of the parenchyma, which alarms or alerts for the surgical intervention. This is another case where the significant obvious obstruction at the UPJ level, where it shows some complication which is showing as a internal echoes into the dilated system, which is due to the serious, leading to diagnosis of the infection or the urosepsis, which also alerts the surgical intervention or the intervention by the stenting. Functional MR urogram, as I said, it is coming up, emerging in the Western countries very fast way, where we can see the swirling of the contrast in the delayed 5-minute phase, followed by the 15-minute phase showing the significant dilatation of the renal pelvis skeletal system, while the other kidney is showing the normal excretion without dilatation. There is the duplicated system plays, the CT urogram plays an important role, where you can see the left-sided system shows the duplex system, where the upper moiety shows the normal excretion while the lower moiety shows the significant dilatation with the contrast held up. This is the image of the functional MR urogram, where the initial phase shows the enhancement of the renal arteries at the same level of the aorta, which shows the anomalous or aberrant artery arising from the aorta passing through the to the lower pole of the kidney, which is crossing the UPJ junction, pelviuretic junction, and that is the cause of the UPJ obstruction, leading to the hydronephrosis and the calyceal dilatation. So complication of the UPJ obstruction is the recurrent urinary tract infection with the perinephric standing, chronic clawing pain, or formation of the secondary renal stones. With the prolonged obstruction, loss of the kidney function can occur, and then before that, it is always important to intervene to reduce this complication. Ureterocele is an abnormal congenital dilatation at the distal most part of the ureter, which can be of the two types, where the intravesical type is mostly seen in the adult patient, while the extravesical or the ectopic ureterocele is seen in the pediatric population, which can be detected by the IVP, or it can be detected antenatally also, as it is seen here in the antenatal ultrasound, which can be direct cystic component seen within the distended bladder itself. As we mentioned that in the duplex system, upper moiety is always sometimes involved with the ureterocele, which is while the lower moiety usually affected by the vesicoureteral reflux. Hirsch diverticulum is another congenital bladder diverticulum seen at the VUJ level, which can be seen as a Mickey Mouse appearance in the voiding cystoureterogram, and can be seen on the ultrasound as the echoic rounded appearance and echoic fluid collection arising from the base of the urinary bladder. Posterior urethral valve is the congenital common cause of the obstructive uropathy in infancy, and most of the time it can be detected by the antenatal ultrasound, which is a very important diagnostic tool to detect the posterior urethral valve, which can be seen as a marked distension and the hypertrophy of the bladder, which can be seen as a bilateral hydronephrosis and hydroinvator in the severe cases, or it can be presented with the oligohydroambulances. Keyhole sign can be seen on the ultrasound due to the distension of the bladder and the urethra immediately proximal to the valve. So here we can see the antenatal ultrasound, which is showing the bilateral hydronephrosis and keyhole sign in the distended bladder with the dilated urethra. Voiding cystoureterogram is an important diagnostic modality to detect the posterior urethral valve, which shows the keyhole sign with the distended bladder with the dilated urethra before the posterior urethral valve. In the early infancy, this is the image which showed the dilated pelvic calyceal system associated with the dilated ureter, with this voiding cystoureterogram showing the keyhole sign appearance also. Vesicoureteral reflux is a abnormality which can be seen as an isolated abnormality, or it can be associated with the other congenital abnormality like the posterior urethral valve or bulbar urethral obstruction or duplex collecting system, and we all know the grading of the system, the VUR. It can be evaluated primarily as by the voiding cystoureterogram or nuclear medicine by the MEC3 evaluation. Also, ultrasound and contrast enhanced voiding urosonography is an upcoming modality to detect this voiding VUR. We all know the different gradings, and I'm not going into the detail of this. So to conclude the part of the imaging portion of the pediatric nephrology, I would like to say that with the standard and the new imaging technologies, goal is to achieve the higher imaging resolution. We should reduce the imaging time as much as possible and minimize the radiation exposure. That these are the main goal for the imaging part of the view to detect the anomalies. The ultimate goal is to fully characterize the congenital anomaly of kidney and urinary tract in the young children with the higher degree of accuracy while providing the non-invasive prognostic information in the patients at risk for developing CKD. We all know that ultrasound is typically the first imaging performed, and it is easily available, non-invasive, and it's a gold standard for the pediatric population. It is used in both antenatally and postnatally, which is important. CT and MRI are useful to confirm the ultrasound detected abnormality, detection of the complex malformation, demonstration of the collecting system in a better way, and vascular anatomy to look for in a better way, which is more importantly for the early detection of the complication like renal calculi, infection, and malignancy are better evaluated by these modalities. The newer modality are upcoming with the emerging modality, which has a promising value in upcoming future with the contrast enhanced ultrasound, which is more important to evaluate the perfusion related abnormalities. Contrast enhanced vesicle urosonogram has an advantage over VCUG standard with the higher sensitivity for the higher grade of the VUR. Functional MRU is coming up with the good promising value with the comprehensive functional information with the improved anatomic information compared with the nuclear medicine too. And 3D printing is important for the surgical planning in upcoming futures. So as a whole, it is kind of a teamwork, which includes actually, I would say, the gynecologist also. So teamwork including the gynecologists, pediatricians, and radiologists, which is essential to be familiar with the various imaging modalities and features of the wide spectrum of the renal abnormality and their complication, which will help in timely diagnosis and appropriate management, ultimately which can help to prevent or delay chronic kidney disease or the end-stage renal disease. Thank you all for listening and paying the attention.
Thank you,
Thank you,
Dr.
Dr.
Tejal.
Tejal. Thank you, Dr. Tejal. It was an insightful journey through the radiological background of preventive CKD. As we started our discussion, and Dr. Anil's major emphasis as one of the commonest source in pediatric CKD is CACUD, and you made a wide presentation on CACUD detection and how to handle CACUD and how you characterize CACUD. That was a wholesome presentation. Now we will open the discussion for open the floor for discussion. Dr. Anil can also be back on panel. Dr. Mohammed, can you check on any questions in the chat box? As far as I could see, I could not gather any questions. If you have any questions in the Google Forms or in the chat, you can open it for discussion.
Sure, let me review. We can also
I'm trying to gather if there are any questions from the audience.
They can either raise head or unmute themselves to ask any question from the audience.
We do not see any questions in the chat box, as there are lots of thank yous to both the speakers in the chat box. I would like to convey those thanks enhanced by my gratitude also. Apart from that, if there are any particular messages the individual speakers want to give, to open the discussion. As the theme was, what was the role of pediatricians? We noticed that CACUT happens to be the major thing that is the source of CKD. Of course, we cannot prevent CKD in CACUT, but then we can prolong and prevent reaching the end-stage renal disease, and that would be the role in early diagnosis. And as Dr. Tejal said, it's a teamwork, and the biggest team player here is the pediatric nephrologist. We would have to refer at the right time because they know how to carry on further with the diseases detected thus. So our common encounters are recurrent UTI, especially in private scenarios. We would hear parents coming with a little grown-up child, 6 to 7 years old, saying the child has had recurrent UTIs. Probably the visit was not for UTI. Child has had recurrent UTIs, and bedwetting is the symptom, for example. So if we have a vigilant screening system or a triad system, and we have picked up hypertension, so this is where it helps, our role helps. Picking up hypertension and doing a routine urine screening in such scenarios would give you, if there is any proteinuria or hypertension, it is a necessary reference to nephrologist. You can do a scanning. You can see if there is any ultrasound scanning which reveals any useful complementary information. And if there is any size disproportionality, then you're already handling. So here I open the question to both the speakers. What are the suggested guidelines? And of course, you both chose not to mention it because these are expected of all pediatricians to know when to refer, what modality to choose in various encounters of UTI. But there are several changes and they become less invasive. What are the recent revisions in the guidelines? Would you both be able to shed some light there?
As you rightly pointed out, Janathan, that the guidelines have undergone significant changes and revision from a very aggressive, evaluation of a child with UTI to a more conservative approach, where you carefully pick and choose the kind of children who need to undergo the investigation and also the type of investigations. So unlike in the past where it was a top-down approach where you do a ultrasound, MCU, DMSA based on the age, irrespective of the risk factors, now now it's dependent on three. One, any child with more than one episode of UTI. Now, when I say UTI, many of the time there is also a problem of overdiagnosis. So anyone with just pus cells in the urine is not UTI. I mean, it has to be a culture proven with symptoms as the diagnosis of what UTI. Otherwise, you'll be unnecessarily investigating a child following the UTI. That is one thing, that a diagnosis of UTI needs to be very specific and sure. The second is to identify those at risk for an underlying kidney disease. That is very important. So as you rightly mentioned, blood pressure is one. If they have a failure to thrive, if they have an abnormal genitals, or urinary stream, especially in a male child, and other signs which I had mentioned, becomes important. The third is the severity of UTI, especially a young infant presenting with urosepsis or a non-E. coli UTI or a UTI that does not respond to a conventional antibiotic within 72 hours. These are the flags, and they need clearly additional evaluations. Now, the NICE guideline clearly says ultrasound may not be required in the first episode of UTI, because if there are no risk factors. But there are differences among the various guidelines. We do recommend an ultrasound in all children with UTI. May not be immediately, but at least after the treatment of UTI, because that's very simple, easily available, and non-radiation exposure, not a harmful investigation to consider. An important point is in examination the genitals, very important, especially in females, even if they may not have any risk except labial adhesions that may be missed. So and that's a preventable cause, because once you release the adhesions, the child doesn't get any UTI, and and there are no other investigations required. The micturating cystourethrogram is now restricted to only 3 conditions. One, in anyone with more than 1 episode of UTI. Second is an abnormal ultrasound, if you find. And third is, anyone, a very young child with a UTI, because that's very unusual to have, unless you identified some local factors because ultrasound is not a very specific for vesicular reflux. You could still have a VUR with a completely normal, no hydronephrosis, and a normal ultrasound.
I completely agree with Dr. Vasudevan. I completely agree with Dr. Vasudevan that there is no harm in taking the baseline ultrasound whenever you come across the episode of the UTI, especially two or more episodes. Then the baseline ultrasound is must to at least to look for any other abnormalities, kidney-related abnormalities. Number 2, it will definitely detect some abnormalities which is missed during the antenatal period, or likely to give some clue related to the vesicular reflux or some other specifically ADPK kind of ARPKD kind of things, which is take us to the further guideline. So I think the ultrasound being the most important and the non-invasive, non-radiation tool, I think that should be done as a baseline investigation. And from there, we should take a call whether to go for further investigation, it is required or not.
Thank you, Dr.
Other point I wanted to highlight was in older children with the UTI, especially adolescent. I mean, especially post-COVID, we are increasingly diagnosing this bladder bowel dysfunction. Merely it's a habit, and nothing wrong with the kidneys or the urinary tract, but merely because of the poor bladder habit, postponing the voiding is another something that we need to elucidate when a pediatrician comes across, especially in an older child with a UTI. So sense of urgency, avoiding postponing maneuvers like crossing legs, Vincent Croce, the frequency of urination. Any child voiding less than 3 times in a day is not very normal. And history of constipation, very important.
And post-void urine assessment by ultrasonologists would help us here.
Yes.
As a passing mention, you mentioned about the labial adhesions. The guidelines prompt us not to do anything until later childhood. What would be your take on it? Would you? Lots of patients come across.
Yeah, significant labial adhesions. I mean, obviously, even in prepucial adhesions and labial adhesions, surgeons, I mean, it's not a surgical indication, but the surgeons do, especially use some creams and to release the adhesions. And especially if there are no other risk factors.
Yeah, application of estrogen creams and all.
Yes. They don't, I mean, so the surgeons, we generally refer it to the pediatric urologist, who will then recommend whether to act on it or not.
It is said on premature release of adhesions, recurrent adhesions can happen, and which again can be counterproductive, causing more recurrent UTI.
Yes. But especially if you find that may be a reason, then that becomes important to address too.
Thank you, doctors. Another dilemmatic situations.
Any rule for is there any rule for the lifestyle modification and dietary modification to decrease the progression of the CKD?
Yes, I mean, of course, there are additional factors that can, apart from the primary kidney disease, especially the hypertension, which can be worsened with obesity. That becomes very important to address too. The nutritional factors like high salt diet, processed food can all contribute in different ways. I mean, it can increase your serum phosphate, your uric acid, apart from worsening hypertension. And also hydration also becomes important, but in advanced stages of CKD, we try to restrict it based on the urine output. And exercise, physical activity. It is not that when the GFR decreases, they have to restrict, but as much as they can do, we do encourage physical activity to help them maintain a healthy lifestyle. And those with an abnormal lower urinary tract, we always advise good fiber foods to avoid constipation, which is a risk factor for urinary tract infections.
And what
apart
about,
from
is there
lifestyle.
any genetic base for the CKD?
Sorry?
Is there any
Sorry?
genetic base and is there any new
Yes,
approach
yes.
for the
So
genetic?
I didn't put this into primary because that is a domain of a specialist. So what has now happened over the last decade is the use of the massively parallel sequencing or the next generation sequencing has resulted in increased identification of specific etiology of chronic kidney disease. And that becomes very important. Like I said, especially in children, younger they are, more likely the end-stage kidney disease or the severe CKD is more likely to be a genetic origin. So genetic testing plays an important role, but I must also say that it has a lot of challenges, especially in the interpretation of results. So hence, these tests should be ordered in consultation with a genetic specialist. Because especially when you identify no variant in a very classical case of a distal RTA, we need to give an explanation to parents. If you identify a variant which they cannot interpret and which is binned as a variant of unknown significance, there also becomes the challenge of whether you have identified a specific cause. But definitely genetic testing has come into the armamentarium of the investigations. I deliberately did not put it into the investigations when I put it the initial part, because that is a specialized investigation that needs a referral.
And what is important also, we can use this one for the prediction also, not only.
Yes, absolutely. The genetic testing is important to confirm a diagnosis or to make a diagnosis, especially when they come with end-stage kidney disease. Everyone looks similar, so we need a specific diagnosis. Third, it helps in the early part, like hyperoxaluria. We now have some newer medications available, Nedisora and all that, which could be used to retard genetic forms of HUS, eculizumab, and so on. Prognostication, antenatal counseling, preventing, especially in families with high degree of consanguinity, it becomes very important. Even if you have a clear-cut clinical diagnosis and you're sure, still to do a genetic testing to help in the antenatal counseling.
We have noticed that it has changed the landscape of CKDs or kidney disorders. How often
Yes.
you happen to be in the department, you happen to be heading the department, so how often do you encounter diagnosing via genetic diagnostics, and how expensive it is, how accessibility is in India, and how you did urge us to consult and order along with the medical geneticists, but how would you give us an approach towards this?
Yeah. So
we have a case.
like in India.
Yeah, I would like to narrate an
Go ahead.
interesting case. This was a case of an RSV happened to travel as Jordan, Bahrain, a child happened to travel in Jordan and acquire RSV and had to be on ventilator, was so dependent, could not be weaned off. Every time they wean off, going into some crisis recurrently, eventually they wouldn't know why this dependence is happening. And then they ultimately got the diagnosis by a whole exome study, and it happened to be distal RTA, meaning there was no way they could diagnose it, and diagnosing that made a difference. So most of the critical care is counting on in ambiguous diagnostic situations to count on molecular genetics. So how do you tell us, maybe it's a little out of the way from the topic that we discussed, but probably in the way also, so you can give us an overview on that.
So one is to identify those children who are going to possibly have an underlying genetic etiology. So any young onset of kidney disease, more likely. Second is parenchymal defects, cystic kidneys or parenchymal defects, ciliopathies, and all those have a high probability of finding a genetic diagnosis. Similarly, with glomerular disease, such as steroid-resistant nephrotic syndrome. The third is a family history or a consanguinity. That is also important factor. And lastly, syndromic manifestations, especially if you have more than one organ involved, more likely to have a genetic, at a high risk of a probable genetic etiology. And then we need to choose a test, appropriate test. There are different types of tests available. And the problem with kidney disease is that they can have a similar manifestation, but many genes involved. For example, steroid-resistant nephrotic syndrome, 30% of them may have a genetic etiology, but 30%, there may be more than 80 genes involved cause that particular, although 5 or 10 are most common, but 80 genes. So we need to know an appropriate genetic testing. But in a primary hyperoxaluria, there are only 3 genes that are known to cause primary hyperoxaluria. So there is a lot of genetic heterogeneity in many of the chronic kidney diseases. So we need to take a panel, and invariably we choose either a targeted panel if we have a very clinical diagnosis that this is a steroid-resistant nephrotic syndrome. But if we have no idea of what it is it involving the tubules or the glomerulus or anything? So then we go for a clinical exome or a whole exome sequencing. And they have their own pros and cons when we go for these broad-based genetic panel. What becomes important is the counseling as to why we are doing it, how we are going to do it, and what are the likely yield we are going to get it, and what are the limitations we may face, and also the need that sometimes we may need to screen the family members to know whether that variant is significant or not. And that many families may be hesitant to consider that testing. So, and the cost in India has come down quite drastically, and that is good and bad. Good because a lot of testing we are ordering for the right patients, but bad because it's being overused. So it's becoming like an easy way to make a diagnosis rather than go through the traditional approach of a good history examination and doing the basic sets of investigations. So because there are mimics, a steroid-resistant nephrotic syndrome could be an IgA nephropathy or a membranous nephropathy also, which can be a non-genetic in origin. So we need to make that first distinction first and then apply for the testing. But not, and it takes 4 to 6 weeks to get the results. So it's never can be used in the immediate thing, but it takes around 4 to 6 weeks. And it costs around 8,000 to 15,000. That's the range of Indian rupees to do a clinical exome or a whole exome.
Thank you, doctor. That was enlightening. Okay, so how do you counsel patients? And precision medicine is exciting when you do get variants of not important significance, or we don't know the significance. How do you handle those situations?
So variant of unknown significance is a difficult a difficult situation because your parents have spent a lot of money. You had a big hope that you're going to crack the diagnosis, and finally you have a very specific diagnosis and you get a variant of unknown significance. Now this classification is very probabilistic based. So when you have a variant of unknown significance, it means that the probability that the variant is causing the disease is between 5 and 95%. So it's a huge range. But there are ways now to distill it to know whether that variant of unknown significance is leaning towards benign or towards a pathogenic or a disease causing. There are more filters available now. Extended family screening. Because if you have a similar phenotype and that phenotype is also showing the same variant, it becomes an additional information. So then doing some functional analysis and additional bioinformatics that needs the help of expertise. But clearly, we conclusively say that we have not ruled out a genetic cause. We will say that we can neither confirm, but we say that this classification may change over time with new information. So it's very important to contact the genetic wherever you've sent to reanalyze it after a year or so to check whether the classification has changed. Third is, in our general principle, we say that it should not be used for antenatal counseling because you're not sure. and then we refer it to the genetic specialist, who then tries to do the clinical phenotype genotype matching and assess. But in general, VUS are not supposed to be used for antenatal counseling. But I agree that that's a difficult situation. We in our lab, we do our own reanalysis and try to at least inform the clinician whether it's leaning towards the disease causing or not.
Thank you, Doctor. Bringing back the discussion to radiology, a question to both of you. What are the recent modalities in current use and current practice in your respective scenarios? What, apart from the ones which are routinely used, the newer modalities highlighted by Dr. Tejal, how often it is counted upon, and what's the utility and what's the current practice?
Still, I think ultrasound is the most frequently available, easily available, and non-invasive modality. So that is the modality of the choice, which is widely used overall by everyone. The use of the other modalities, especially in certain cases like a reflux, again the voiding cystourethrogram is again preferable. And contrast enhance and some of the other advanced technology which I have mentioned is actually used in the developed countries rather than especially if we think about the scenario in some of the centers in the India or even in the Middle East. The majority of the countries or the institution, these kind of the advanced technologies are not available so far with the proper expertise. So that is another limitation. But in the developed countries, some of the advanced, especially the functional MRU is coming up with a very significant way to proceed further in certain cases like reflux or in the obstructive pattern or the duplex system with the obstruction to look combinedly for the function as well as the anatomical details. So rather than going for, in those countries now they are using functional MRU, because rather than going for the anatomical ultrasound or CT and complemented by the nuclear scan, this is coming up as a combination of that study. But still, as a part of the basic investigation and commonly available investigation, still ultrasound and voiding cystourethrogram are the basic investigation, followed by nuclear scan, and then if necessary, CT scan. Because MRI per se itself has a lot of other limitation. Main limitation is the longer duration of the study where the child has to be inside the gantry without moving, which is another challenge. So that's the main challenge, I think.
Yeah, exposure to radiation seems to be the major advantage. We are counting on the new modalities. And Dr. Anil, what would be your take on the current modalities in the Indian scenario?
I agree with Dr. Shah that ultrasound continues to be the most common imaging modality because it's a well-done ultrasound helps us in many ways. I mean, and we also sometimes do a high-resolution ultrasound to pick up those small cysts, which can help in the diagnosis of an ARPKD. And a comprehensive ultrasound means mentioning the kidney sizes, cortical thickness, dilatations, bladder volume, pre and post void thickness, all that gives us enough information. We do CT, non-contrast CT, when we suspect a stone and we are not able to identify in the ultrasound because small stones can be missed. Like we have a child with pain abdomen and a flank pain. It shows mild hydronephrosis, but the stone isn't visible. Then the CT is a useful modality to identify the precise location of stones. Our MR is restricted to duplex system because MR urogram is a very good investigation to delineate the complete anatomical architecture of a duplex system. We definitely go for that and don't rely on a CT or a ultrasound merely to diagnose, because the surgeons need a lot of information to decide how to go to manage that. In the renovascular hypertension, the additional investigation we do use is a direct, digital subtraction angiography. That's a gold standard. Although we use Doppler as a screening tool, but it's a very operator dependent. CT, again, I mean, advantage of a direct angiography is we can intervene in the same setting and like in the CT, and MRI also, and also you can see the peripheral vessels. So these are some of the few additional investigations in very specific situations that we do. We also do it when we are not sure of the cystic kidney disease. We may rely on CT scan to pick up those cysts to make a diagnosis, because there are some criteria to diagnose ADPKD, especially in those 14 years of age.
Can contrast ultrasonography be suitably replacing the CT for the same indications?
There is still a time which will take this modality to take it further way in an advanced way and more easily available way, because most of the institute it is not easily available, particularly those microbubbles which are used as a contrast agent and needs appropriate expertise. So as Dr. Vasudevan mentioned clearly, that still the grayscale standard ultrasound is the gold standard for the basic evaluation, and up to certain limits it gives a lot of information, so that is required for the to take it in a further manner. Other thing I would like to mention is that however we said and done, that in certain up to certain level cost is also in fact in particularly in India or somewhere in limitations where the immediate advanced technology or modality cannot be used immediately. As long as we get enough information by ultrasound without radiation, I think that is the standard way of evaluation.
Okay, thank you, doctors. That was really interesting and insightful. As I don't see any more questions coming up in the audience, it has become our discussion. To summarize the message to the pediatricians, we will have to be vigilant and a little more proactive in high-risk situations, beginning from antenatally detected CACHUT and routine hypertension screening in the office practice, proteinuria screening. These are all vital role that a pediatrician can play. Getting a routine ultrasound done in risk situations would go a long way in prevention of CKD, which happens to be one of the major problems when gone undetected. We all know kidney suffers silently and left undetected. Most of the time it's asymptomatic. Routine screening of serum creatinine, proteinuria, hypertension, renal ultrasound, these all seem well within our reach. And when we do not do it, we are missing the bus. So this happens to be the message of today's discussion. As a closing remark, I would want Dr. Anil to give some message and Dr. Tejal to give a message to the pediatric audience before we wind up.
I just want to just mention and stress upon that chronic kidney disease is not something rare in children. So among all the differential diagnoses that you consider, probably CKD, kidney disease also should be in that list, especially because the challenge, like I said, was non-specific and a very heterogeneous clinical presentation, which could mimic other organs. And the investigations are not very expensive. A simple urine routine, blood pressure check, a serum creatinine, and if possible, an ultrasound kidney would be enough to pick up most of the kidney disease.
Noted, Dr. Tejal, message from you.
I agree with that point, and from imaging point of view, I think the basic ultrasound is the most important tool, which should be advised to do it as early as possible and as and when required, depending on the clinical scenario. Other thing is I would like to emphasize is that as and when there is some abnormality detected on the antenatal ultrasound, make sure that these cases are followed in a very effective manner. So that can actually give us a lot of other early detection and prevention.
Thank you, doctors. Thank you very much for this highly interesting discussion we have had. I would request Dr. Mohammed Salman to give the vote of thanks. Thank you all for attending the session, and thank you, Dr. Anil and Dr. Tejal, for a very interesting and insightful presentation. Dr. Mohammed, can you give the vote of thanks?
Thanks for our speakers, Dr. Anil and Dr. Tejal, and all the audience who stay with us till the end, and looking to meet you again next month on our regular webinar. Thank you.
Thank you. See you all the next month, 4th Sunday. Thank you.
Vinita madam, you can
Bye,
end the
everyone.
session, ma'am. Madam, you can end the session.
I will.
Please.
Yeah.
Yeah, please end the session.